diabetes, but had never really, taken care of it. So he went home with all of these new things. And so when he came back from appointments, he had 5 appointments in one day. So I was able to go with him to these appointments to make sure that he understood the information and was able to pull it all together, summarize it. We kind of keep a little list of, okay, these are all the changes. This is the change that this doctor made, this is the one that this, and so then we just keep kind of a running tab for the patient for that day at the clinic, and then we can give it to them at the end of the day and say, these are all the changes that you made. If you get home, you have questions, you can call me, rather than them having to call back to all these different departments with questions. We can do that. And we're also the knowledge worker, and that's, for nurses in any role. Like I said, a lot of these roles are very similar to the nurses in the clinic and hospital, but we're able to carry these roles across a long time frame with these patients. We really assess the response to the interventions and services. A lot of, like I said, for this patient that saw 5 different doctors, or even when they're in the hospital and they have, how many new diagnoses. Like I said, they may have had open heart surgery, and then their diabetes is diagnosed, and then maybe during their hospital stay they develop heart failure. So they're going home with all this new information. So really, we are there to do that assessment of how are they responding to all those interventions that were, given to them when they left the hospital or clinic, and incorporating that. And sometimes we have to do some negotiating with the providers to say, this isn't working for them, can we do this? So we do, communicate back to those providers. And then navigator, we really help them navigate through the healthcare maze. And it is these days, it is a maze. Some of them do feel like little mice run through the maze. As they go and try and connect up with all their providers that they have to connect up with, or even in the hospital, they have all these people. And we're a teaching institution, so we have the doctor come along with his residents, so it looks like there's a lot of people that are involved in that patient's care. So it's just trying to help them sort through who are all these people coming in, and what are they telling me, and if they're maybe sharing with us that I don't want to do this test that this doctor, suggested, I want to wait. And I've had that happen. And so really we have to kind of step forward and advocate for that patient and say, they just can't do it now. They just want to go home, they'll come back, and a lot of times the doctors will respect that and will work with us on that. And we had a patient that had several different people that were trying to ask them to do different things, and we again had to, there's a lady who, she would call me, she'd be crying and laughing, and within a 5-minute time span, we're like, she is not handling any of this information. She had cancer, and she had a heart problem, and she had the pulmonary docs, and she had her internal medicine. So I had to really say, who are you willing to work with? Which doctor? She was so overwhelmed with all these appointments. And so we just narrowed it down to her primary doctor and her hematologist. And I contacted her primary doctor and said, she's got all these cardiac meds and pulmonary. Are you willing to prescribe those for her now and take that over until we can get her back in with her, her cardiologist and pulmonary? And they were. So it's really, some patients we add providers to their, to help manage their disease process, and sometimes we have to narrow it down so that patient can, mentally handle all the people that they're dealing with. We're also the traffic controller. Again, it's kind of the same as the navigator, but we really, again, like the same way to try and keep it manageable for the patient and family. Who are they dealing with? A lot of times we try and get services in their home, but sometimes that's overwhelming for them. So we just really try to do a lot of negotiating and working with the providers and working with the patients, seeing what's going to help them manage the best. And then care coordination is done through Lutheran. Some of the, so we are an integrated healthcare system. And some of what you may hear about care management or case management, some of it is more insurance-based and it's over the phone. Maybe they're managing that patient. Some places may have, care managers in the hospital and then care managers in the clinic, and there are different people that are helping that patient manage. You don't really go across the system. Whereas at Gunderson, we are an integrated healthcare system, so as an employee, I can follow that patient wherever they're at. You know, I can document when they're in the hospital, I can document when they're in the clinic, I can take orders, you know, it's just, I can be available for that patient in whatever setting they're in at that time. So it really does help that flow, that patient flow, a lot better for when they're in the, coming to their appointments or in the hospital. We do have, like I said, we have an electronic health record which helps, so we have access to those notes, you know, clinic notes, hospital notes, emergency room, lab reports, x-ray. It's just you can go and click down, and it helps us keep track of, you know, if the patient been missing a lot of lab follow-up or follow-up for tests or appointments. And then we do have regional clinics. We have 21 regional clinics. So in all those notes, as long as they're seeing a Gunderson provider, all those notes will be in that record. So we can see if when they're seeing their local provider, you know, 60 miles away, that note will be in there. Or if they're into their local emergency room with the Gunderson affiliate, then we can see those notes. So it does really help us manage those patients better. And that's another thing I know that the healthcare reform is really looking towards, an electronic health record for all patients to keep that information straight. And the program, the care coordination, and I'm a nurse, but then as a department, we have nurses and social workers. We felt as a nurse only that when I went into this role, I said as we were planning this, you know, because we were always looking at the right person doing the right care. And so a lot of the clinic nurses that were, you know, in internal medicine and family practice said, I'm doing a lot of social work, you know, setting up services, setting up home health, Meals on Wheels, whatever. So I said, you know, and this role is going to be for the very complex patients. I said to the planning people that we were working with, that we really need social workers to work with us, to partner with us. And that has been the best, you know, team work, because these patients do have a lot of needs, and I don't know all those resources. So we do have, we work closely with them. We work with multiple providers, like I said, across the continuum. We also, not only within our facility, but we branch out into the community. Patients may have home health, they may have county nurses, they may live in an assisted living, and there's a nurse that works with that assisted living. And they like this role also because they have we are one point of contact for that patient. They may have several providers, and that nurse, that's, you know, the home health nurse or, you know, community and county nurse or assisted living, can call us and say, his weight's up, he's short of breath, his sugars are up, he's got pain, you know, can we get some answers here? So then we take that phone call and we can call all those providers and say, okay, this doctor wants to change this and this doctor wants to change that. And so then we can call that nurse back to that assisted living and, you know, reshape the plan for that patient where she doesn't have to be spending her time calling all these different departments. So it's not only satisfying for the patient's families, but for those providers out there of those very complex patients that they feel it's helping them manage the patients better. And really the goals when we developed this program, we thought, what, you know, these complex patients, why are they complex sometimes? A lot of our referrals can come from the emergency room and urgent care. They're what they call their frequent flyers. You know, they're in and out of the emergency room, they're in and out of urgent care. Why are they there? A lot of them don't have primary providers. And was going to ask a show of hands, how many of you have a primary, like internal medicine, family practice doctor? Because a lot of our patients will say, I've not been sick. You know, I don't need to have a, you know, regular doctor. I don't need to go on. A lot of it, like I said, our society is so, you go when you're sick, you don't go for prevention. So that's our goal, is to really work with these patients to help them get a primary provider so that they can start to do some of that preventative health care. And again, it's the insurance coverage. We know that. You know, when we have patients that have no insurance, then we really have to be thoughtful of their situation and not, you know, having them come in for a lot of appointments or, you know, are we over-duplicating on medications? So we really try and help them get to what they need and can manage and afford and look at the whole picture for these patients. Because medical, it's psychosocial, it's financial, it's, you know, how can they manage best with what they're dealing with. We also coordinate services and resources for the patients. We help see what's in the community or even at our own institution that maybe that doctor didn't think about. If the patient who's having some vision problems, we have a low vision clinic, and maybe that doctor didn't think about referring that patient to that low vision clinic. So we really, when I went into this role, I thought I just started opening up. I had been in Gunderson for 20-some years already, but didn't know a lot of the outpatient world. I had been in the hospital and the inpatient world really well, but didn't really know the outpatient world. So I opened up our internal phone book and started flipping through and thought, well, I didn't realize we had this. I didn't realize we had this. So really, as in our department, we expose ourselves to that whole outpatient world too, and we're also the inpatient world. So we get to know a lot of people in different environments. But it's really, like the pain clinic, and because some of the doctors just don't, you kind of get enmeshed in that patient's problems, and you don't think outside of their department. So we really try and speak up for that patient. So what about, could we get, this other service involved? We really try and increase the appropriate use of outpatient services. Again, trying to get them in for their clinic appointments, stressing the importance of that versus letting things get so bad that they end up in the emergency room or in the hospital. So helping them, one of our main goals is to help them manage their disease process the best that they can. So really, trying to help them keep the appointments that are as appropriate, frequency. Sometimes the doctors get overzealous and they want them coming every week, and we're like, the patient just can't afford to come back and forth that often. Or we try and coordinate all the appointments on one day, especially if they're driving. Some of our patients drive an hour, hour and a half to come to their appointments. So it's really, what does the patient want? Do you want all your appointments in one day, or do you want to come back for, one appointment, or a couple appointments one day and some later in the week? So we really work with what they're able to handle. We're trying to reduce visits to emergency and urgent care. When we have a patient that we're involved with, we really encourage them to call us if they're having problems at home, so that we can help try and decide, is it something that they need to come in for, or is it something that we can get them into their regular doctor, or maybe we have a lot of nurse practitioners that work like in internal medicine and family practice, and even in a lot of the specialty departments, that maybe their doctor is busy, but we can get them to see that nurse practitioner, somebody that knows that patient, versus having them go to the emergency or urgent care where they really don't know them, and then you're kind of starting all over again. So we really try and help facilitate that, and not just have the patient automatically run off to the emergency room or urgent care. It's not that we don't want to know them there, but we just want to make sure that they're using that appropriately. And we also want to decrease hospital days of admission. A lot of times we have these patients and we know what's been going on prior to the hospital stay. So when our patients get admitted, a lot of times the emergency room doctors are very good at looking to see if they have care coordinator, and they're calling us up. I've gotten calls from the emergency room doctor and saying, what should I do for this patient? And I thought, you're the doctor. And a lot of times I'll say, this is what I've tried to do, outpatient. This is what we've been doing in the last few days or weeks, and we've tried everything. So I mean, if the doctors who you've worked with, if they've tried different pain meds, if they've tried different, this one lady was 53 years old and she has chest pain and she had open heart and diabetic, and again the psychiatric, underlying depression and anxiety, and she just has a hard time making it. Sometimes she'll call me 5 times in a day. She just has a hard time getting from morning to night some days. So we can do that reminder. Okay, did you do, we have a daily plan for her. Did you take your medicine this time? Did you listen to your relaxation tape? Did you, do your exercise? So it's just very basic things, but it's just going over it with her. And, I'm her one point of contact, so she doesn't have to call in different people. And again, like I said, I started out in this role as a pilot 6 years ago, and there was also a care coordinator in the region. And so over time, we've added more care coordinators, and currently we have 24 registered nurses, 4 social workers who we work very closely with. We have 2 office assistants who help us keep our statistics, all that information that they want to know about as far as, how many of them have Medicare, how many have medical systems, and where the referrals are coming from, and they help keep track of all that. We also have 3 nurse care coordinators who specialize in pediatrics. we really felt that that was a population of patients who needed, someone to help them manage through that healthcare maze. The kids that come out of the NICU with trach, tube feeding, they've got neurological deficits, and we're going to have a ton of follow-up appointments, and the parents are looking like, deer in the headlights when they leave the hospital going, okay, I've got this little baby now, and how am I going to manage it at home? So that pediatric care coordinator, we really try and, if we get a referral for a hospital patient, we try and meet them during that hospital stay, be involved during that hospital stay, and then we're that contact when they leave the hospital. And then when they come to appointments, we're there at those appointments. And we try and be at all appointments. Sometimes we have 3 of them at once, 3 different patients, so we're running from place to place, and we may be calling that doctor saying, I can't be there, let me know what happens, and we're following up with the patient afterwards. And we also have 2 nurses who specialize in behavioral health care coordinators, and they, a lot of our patients have underlying, depression and anxiety, but for those patients, their mental health diagnosis is at the top of the list. They may also be diabetic and have some heart failure, but they are mainly seeing their mental health providers and follow-up. So we love them. And all of our nurses, we have years of experience. We're not old, we're just wise. So we, a lot of us come with different backgrounds, and when I help interview for all of the positions that we have, and we really looked at what are the backgrounds of the nurses. So we have some with cardiac, pulmonary, hematology, oncology, hospice, home care, intensive care unit, rehab. So we have a wide range of backgrounds in the nurses, and it's a great group of nurses to work with because we really bounce ideas off of each other. What do you think I should be asking the doctor about, this patient, if you're not as comfortable? I have a patient who was diagnosed with breast cancer, and, I read the pathology report, but I didn't really know in detail, is this really a bad breast cancer, or is it one that's going to be very treatable, or what? So she was able, I went to the nurse who has been in cancer for, working with cancer patients for years, and so she was able to help me learn, and so we're always learning new things, and like I said, you go to these appointments, hematology, and I used to work in coronary care units and more cardiac, and didn't know a lot about hematology, so we're always learning also as we go to these other departments. We get along with the patient, we're taking notes, trying to get it very basic for the patient. We also have a nurse now, too, that works in chemical dependency. That's some of our patients. There are a lot of pain, patients with pain issues, and who the doctors don't want to deal with. They're just an addict. They just want a prescription, and we really try and advocate for those. There's some patients who are like, but we need to come up with a plan. They've got pain. We need to come up with a plan, and everybody kind of wants to shut the doors to them. So she's been a great resource as far as helping us know where to kind of get the patient, who to work, who for that patient to work with in the system will work with those chemical dependency patients. And each nurse, we have about 50 to 60 patients on our caseload at a time. We have patients discharged, on and off. As far as our program, we have about 1,000 patients active at any time for all the care coordinators. And the social workers follow between 70 to 100 patients. They, like I said, set up services, and then they kind of rely on us to get back to them if those services aren't working. Then we discharge patients, and then, 3 months down the road, something happens, and we reactivate them, and so we never really throw away the information that we've saved on, put them in the file, and then we pull it back out again. There's a lot of it. You get to know their family members, and there's different little idiosyncrasies. We try and get that all in the records. We want it all recorded, but it's just good to have that file to go back to. And we are a tri-state region in La Crosse, Wisconsin, so we are right between Wisconsin, Minnesota, and Iowa. So we have patients that travel from all those different states, the other states that come to La Crosse for their care. But where the care coordinators are located, we have most of our care coordinators in La Crosse and Onalaska, and those 2 towns are probably about 8 miles apart, so we travel back and forth. And we have Toma, Rocco, Curtis, Union, and West Union, so we kind of circle around La Crosse. And this has been over time that we've added these regional care coordinators, because a lot of patients have their primary provider in their region, and then a lot of our specialty doctors travel now to those different regions. And they're very complex patients, and a lot of times it's in very poor communities. one of the counties that is right around the process, Portis County in Wisconsin. So you have a real, the social workers have a real struggle as far as resources and, not only for the patient, but through the county trying to get them help. So they work very hard with, working with our patients. And usually when the doctors come in and maybe it's a new patient for that doctor and they see one of us sitting in the room, they just go, oh, they've got a care coordinator. I know they're not going to be easy patients, So they the doctors have been very supportive of our role. Because a lot of times they'll say to us, this is what the patient needs. We follow up on this after, when they leave here. Because the doctors aren't wondering, is this going to work for the patient or not. So we have a very, great relationship with the providers. We do provide it to patients at all ages. Like I said, we have the pediatric care coordinators, but even for us that deal with the adult population, we take patients from, 18. A lot of times some of the pediatric care coordinators have patients who have been developmentally disabled, and now they're 18, and now they need to transition to the adult world. And we're having a real struggle at the institution trying to find providers that will work with those types of patients. The pediatric, they have that very established in the pediatric world, but in the adult world, we're working on trying to find providers. So then some of those patients get transitioned to the adult care coordinators, so we take those patients on. And it's at no cost to the patient. It's just how, as an institution, they decided that they wanted to manage these very complex patients. So the patients aren't charged for our involvement. We just help manage them, like I said, through the healthcare maze and try and keep them on track. And when we developed this role, we developed a criteria, and I'll be going over that in a little bit, but one doctor said, well, I could refer all my patients to you. All my patients have all these problems. So we really said it's when, you could have two patients who have the same diagnosis list, same med list, but some patients can handle it with a good support system and family, and some patients just can't. So it's really those patients that are having difficulty managing their complex health care that we get involved with, and just trying to get them on the right track and get them connected with where they need to be connected with. And they'll call us with a referral, and then we evaluate them for care coordination, and we contact the patient and get going with involving their care. So this is our referral criteria. There are multiple medical diagnoses, most of them. Usually when we get a referral, we can say, okay, before we even open up their chart, we'll say usually they're heart failure, diabetic, they've got COPD, asthma, we pretty much know what they've got, heart and the diabetes and a lot of multiple diseases. Usually a lot of them have multiple providers. They've got a primary doc, hopefully they have a primary doc, and if they don't, we can them in with one, or some patients, we have a lot of specialty doctors, but not a primary doctor, and nobody's pulling it together for that patient. So we really look at the whole picture. My 36-year-old patient that I have, he has 8 doctors. He's had open heart, he's had stents, he's diabetic, he sees podiatry, he sees endocrine, he goes to physical health, orthopedics, he fell and broke his leg, and just trying to manage him is still a great challenge. And then the medication management issues, that's probably one of the biggest things that we deal with is, patients who have medications and they can't afford to get them filled. Or their insurance coverage is changing, or they can't afford the co-pays. So with the economy the way it is, it's huge, with trying to help patients manage their medications. And, when they don't manage their medications right, that's one of the biggest reasons for readmissions to the hospital. So that's what we're really focusing on. We usually apply for a grant, and we have medication boxes that we can, take out to the patients and give to them. A lot of the times they'll suggest a pill box, and the patients will be like, oh, I'll go get one, and then you see in the next one, oh, I haven't gotten it yet. And, so that's why we just went ahead and, like I said, we applied for a grant, and we always keep pill boxes so that we can give out to the patients. So it's just, it's not an issue then. Multiple TEC, that's our emergency room and our urgent care, but we kind of talked about that. Usually they don't have a primary doctor that's trying to pull it together for them. Or I've had a younger lady who she was going to the emergency room and urgent care, and different complaints and was getting pain pills at both places. So sometimes it's to get involved with some of those patients to decrease their access, and to help find them a primary provider who will deal with their pain issues. That's the thing too, is maybe they don't have a doctor who's willing to do that. So finding somebody that will, and a lot of times we put on their problem list, narcotics only to be prescribed by Dr. So-and-so. So then they keep a rein kind of on managing that patient's pain. Otherwise you've got different people ordering different things and who knows what's working. So, and then multiple inpatient admissions. And the one thing if you're, when you're working in the hospital, the good thing to ask yourself is, why are they continuing to come back in? What's missing? What's going on that they can't manage their heart failure or their diabetes or whatever at home? Is it that they don't have the right medicines, or is it that they didn't understand the information when they went home the last time? So that's, if you get out into the working world, as some of you probably already are, out in the hospitals and clinics, emergency rooms and urgent care, to really ask yourself why are they, coming in so often. And when the patients are in the hospital, there's a lot of times they may come in on one medical unit, and the next time they're in with a different medical unit, and there's different staff and different doctors, and so then nobody's really putting the whole picture together for the patient that this is their third admission, So we really try and work with the hospital staff and help them identify those patients so that we can get involved and help prevent them from coming back in again. And again, we've kind of talked about some of the psychosocial issues along with the medical complexities. Depression and anxiety impacts their ability to manage their medical issues, their diabetes. My gentleman, he'll get up in the morning and he won't monitor his sugar for days, and then he'll come in with his blood sugar of 400. And so it's just trying to get, figuring out what is it that, even if you can just do it once a day, it's negotiating with them. If you can just, the doctors may say, you have to check your sugar 4 times a day, you have to do this, But we negotiate with the patient and say, can you please do it once a day?